Today we will present a video of a Greene lasso suture for the correction of high hyperopia secondary to a radial keratotomy performed more than 30 years ago. Here we can see the case with 16 radial keratotomy incisions. Using the digital marker of the Callisto system, we will mark a 7 mm circle in order to pass the first suture. In this case, we'll be using 2 sutures. Once the mark is made, they are at 7 mm, and we also have the mark at 8 mm. Digitally, we will begin to pass a needle with a 10-0 mersaline suture, which is a material that is sufficiently rigid and non-absorbable, so it can remain permanently inside the corneal parenchyma. We begin by passing the needle in the area between 2 incisions, as deep as possible, and we will pass it superficially every 2 incisions. Here we are going deeper. We exteriorize it approximately between 1 incision and the next, and we slowly perform the lasso suture technique. We can see how we carefully exteriorize the tip in the corneal parenchyma. We must be careful not to compress too much to avoid any reopening of these radial keratotomy scars, which frequently, if excessive pressure is applied, can open up and require suturing or result in poor healing. We continue completing the circular suture, always going as deep as possible. This way, the suture will remain buried in the corneal parenchyma every 2 incisions and will pass over the next incision, alternating. We try to digitally follow the marks we have made, and we will complete this first circular suture. When we tighten it, it will cause the corneal apex to curve. As we will see later in the previously performed topographies, it was actually very flat, causing significant hyperopia. So now we complete this first circle of suture, and we will knot and tighten it to produce this compression towards the central zone, which will cause the corneal apex to curve. We are going to make a 1-1-1 sliding knot. Here we have the first pass. Then we will tighten and slightly explore the path of the suture. And now we will tighten the knot. We gradually apply slight traction to try to obtain the maximum possible tension, since in the postoperative period in these cases, there's usually a loss of effect as the suture gradually loosens inside the corneal parenchyma. But we observe that the suture breaks, so we are forced to perform a repair on it. We observe that it is the lower area that we will have to pull out of the channel to have enough thread to make a second knot. In this case, we will have to have 2 knots on this suture on this pass. Here we are making the repair knot. To do this, we make a 1-1-1 knot. We very carefully trim the ends as short as possible for a clean finish. And we will proceed by pulling on the superficial area to bury this knot underneath in the corneal parenchyma. Next, we will complete the second knot, and we will pull until we obtain the greatest possible circular tension. And we complete and close the knot. Next, by pulling on the parts of the suture that pass through the epithelium, we will gradually pull until we bury both knots in the corneal stroma. They should not be left exposed to avoid causing postoperative complications. And then, carefully, cautiously, we will adjust and distribute the tension around the 360 degrees. Once this suture is in place, we will place a second suture, approximately 1 mm outside the previous one. We complete it and also bury the knot in the corneal parenchyma, and then place a contact lens. Here we have the immediate postoperative result, in which we can see the sutures are correctly buried. We can also see the depression that these sutures form on the corneal surface, where we can observe these pools of fluorescein, which will gradually subside. Here you can see with the anterior segment OCT the depth at which both sutures pass, at approximately 70 to 80% of the corneal parenchyma. And here we have the case preoperatively, with very flat curvature radii in the central zone of 31-32 diopters. Here we have the holiday map of corneal powers in the central zone, 32-33 diopters. And here we have the result 1 month later, with a steepening, as we can see here, up to 35-36 diopters. And in the maps, we can study the refractive change. Here we have a minimal astigmatism of approximately 1 diopter, 1.5 diopters. If we manage to properly redistribute the tension across the 360 degrees, in the EKR, we see that the steepest meridian has steepened to almost 39 diopters. And in the comparison map between both exams, we see how both the anterior and posterior curvature radii have changed very significantly. This has improved the patient's hyperopia of 6 diopters, and without correction, the patient achieves a vision of 0.7.